My name is Annalisa Baldonado. I am a Doctor of Nursing Practice student of the Northern California DNP Joint Program of San Jose State University and Fresno State University. Today, my presentation is about avoiding readmissions initiative. The objectives are to introduce my DNP project and share to you the project context and methodological approach, and lastly, the evaluation process. Readmissions is a hot topic today because a healthcare organization's high readmission rates are considered a mark of lower quality care. CMS can actually penalize hospitals for excess readmission rates. In this table are the penalties. For year 1, conditions include heart failure, MI, pneumonia, which equivalent to 1% penalty. For the succeeding year, conditions are COPD, coronary artery bypass graft, PTCA, and vascular procedures, which equals to a 2% penalty. And for the succeeding year, it expands to other conditions, equaling to 3% penalty. We are not talking about just hundreds or thousands of dollars, but this can amount to millions and millions of dollars of penalty. So that is a large amount. Transitions of care is a vulnerable time. I want you to stop and think what happened to that patient you discharged. Do you know that 62% of medical patients had an adverse event? 72% were adverse drug events. Other types are readmissions, ER visits, pressure ulcers, infections, and falls. How about from the patient's perspective? According to the study done by Macarius and Friedman during their post-discharge phone calls, 41.9% could state their diagnosis, 27.9% could list their meds, and only 37.2% knew the purpose of their medications, and an alarmingly 14% can state the common side effects of their drugs. I want to bring you to my hospital setting, which is the Veterans Affairs Palo Alto Health and Hospital System, which consists of 3 inpatient facilities located at Palo Alto, Menlo Park, and Livermore. We have 7 outpatient clinics, namely San Jose, Fremont, Capitola, Monterey, Modesto, Stockton, and Sonora. We are a teaching hospital, and we operate nearly 900 beds, including 3 nursing homes and a 100-bed homeless domiciliary, serving more than 85,000 enrolled veterans. And also, we are a research center and affiliated with Stanford University School of Medicine. Now, my PICO question is stated as: population are adult heart failure veterans, intervention, transition coordinator advocacy plan. My comparison is the current practice with an overall outcome of: the general outcome is to avoid readmissions. Now, my PICO question is: among the adult heart failure veterans, will transition coordinator advocacy plan compared to current practice avoid readmissions? I am implementing the Project RED, which is a re-engineered discharge. It has 11 elements and a random controlled trial aimed to decrease readmissions by 30% and also increase patient satisfaction. This is a 7 years work of Boston Medical Center, who had funding from AHRQ and NHLBI. It is a safe practice endorsed by IHI, LEAFRAG, CMS, and exceeds the standards of the Joint Commission. I want to share to you the success stories of Project RED. In Glacier Ridge Hospital, their pneumonia readmission rate was 4%. Post-implementation went down to 0%. For their COPD, 20%, down to 14%. Now, for Northwest Lake Forest Hospital, they had 38% pre-implementation on the all-cause readmission rates, and post-implementation went down to 10%. For Temple University Hospital, for their heart failure readmission, they started at 24% down to 12.8% post-intervention. Really interesting. What are the red elements? These are educating the patients, scheduling their appointments, discussing their tests and studies, also organizing their post-discharge services, doing medication reconciliation, using national guidelines, and reviewing to them what to do when a problem arises. Included also is expediting the discharge plan to the next clinician, doing teach back, follow-up phone calls after hospital care plan use, and lastly, the language assistance. In the previous slide, I stated it was 11 elements, but in actuality, currently it's 12, which is the addition of the language assistance. Now, for my cohort of patients, I look at the populations at risk. The first trajectory are healthy veterans with new onset of new chronic illness because they are still in denial. They are still adapting to these new chronic illnesses. And the trajectory 2 are veterans with multiple chronic illnesses. The third trajectory are veterans at end of life. I want to share to you my SWOT analysis. S for strength. The strength of this DNP project is that it's a quality improvement, avoiding readmissions initiative using Project RED, which is an evidence-based solution. It is recommended by reputable sources and major organizations, and we in VA Palo Alto are the first organization to implement the 12 components. It was initiated in an inpatient hospital setting, extending to outpatient services. The strategies are patient-centered, teamwork, collaboration, implementation of evidence-based solutions. It is a continuous quality improvement with the use of informatics and commitment to safety. The weaknesses is the implementation of the after-hospital care plan as we try to integrate it to our EMR, which is causing a lot of challenges that takes our time, thereby resulting to a low enrollment to our Project RED program. There are multiple processes involved and no standardization. But there are a lot of opportunities here. One, and most importantly, is improving the veteran outcomes across the nation. And again, as I say, we are the first in the nation to lead this initiative for the VA systems. Our processes can be duplicated, and we ask a resource to other hospitals. And also, it provides us many opportunities for evidence-based projects and research, thereby an opportunity for publication. What are the threats? We need more resources, just as other hospital organizations. We need more buy-in from different stakeholders, especially referrals to palliative and hospice care. There are barriers. There are staff who are really resistant to change because of politics and culture. Now, the heart failure model I am gonna use is a discharge strategy and a pilot study. I have 30 patients, and the inclusion criteria are male, a diagnosis of heart failure with a telephone. Excluded to the study is our patients who are transferred from different hospital under hospice care, admitted for a planned hospitalization on a hospital suicide watch, who are deaf and or blind. I am comparing the usual process with the transition advocacy plan. The process includes the use of risk calculator, risk assessment tool, educating the patient with the use of the 12 elements of Project RED, and also the health literacy tool, motivational interviewing, and the use of internal email that is encrypted. It is a communication and collaboration between the clinics and the inpatient team, giving them updates when the patient is admitted, if there's any changes, and when the patient is discharged. Included with my TC collaboration is the use of clinical pathways, networking with community partners, which is the clinics, home health services, and skilled nursing facilities, and the use of home telehealth. I do follow phone call post-discharge, and I am available for any calls if the veterans have any questions. The methodology. So, as I stated, my project is a quality improvement in concurrence with Project RED. It is a pilot study. It is a preliminary investigative feasibility in a really small scale and exploratory in nature. Thereby, it is an exploratory descriptive design. Once I am able to lay out the strict steps, then I will proceed and make this as a research study. Now my timeline, this is my Gantt chart, so I'm just gonna state the highlights or the milestones of this project. So I received approval from the Stanford IRB last April and passed my QA qualifying assessment last May. The Fresno IRB approval was last June. Our first publication was on print last July, and the implementation was last August 23rd. I started and continue to collect data and looking at poster presentation opportunities, and with the hope to publish the second manuscript by the end of January and the project completion by April of 2014. The evaluation part includes the return of investment, wherein the formula would be gain minus investment divided by investment. I'll be looking at the cost and benefits, which leads to beneficial return. It has two prongs, which is financial and non-financial. I will not focus on the financial only, but also on the non-financial part, which includes the education. I will look at if there's increased knowledge for self-management, and for the communication and collaboration, if there are improved connection with PCP and other providers, improved medication compliance, increased patient satisfaction, and the implementation of national guidelines. For the readmission rates for heart failure patients, I will be looking at hospital utilization and length of stay. In summary, I have provided you an overview of my DNP project, presented my evidence-based model and its methodology, and also my evaluation process. As a VA employee, I would like, if you would please allow me to state that we strive to exceed the expectations of veterans and their families, and we strive to perform at the highest level of our competence and take pride in our accomplishment. Thank you so much. These are my reference, and if you have any questions, please post it. And again, thank you for listening.